Well, welcome everyone who's on this webinar. We're going to be talking about men's health, particularly erectile dysfunction. My name is Dr. Richard Heppe. I'm a partner here at the Urology Center in Colorado. I'm originally from Virginia and have been in practice here in Colorado since 1991 and specializing in men's health that entire time. Today we're going to be talking about erectile dysfunction, particularly how it relates to other aspects of your health and how it can be the so-called canary in the coal mine because it can be a harbinger of things to come. Also, we're going to be talking extensively about treatment options for erectile dysfunction because this is such a common problem for men. So erectile dysfunction, we're going to talk about what it is, who has it, what causes it. We're going to talk about how it's related to diabetes, coronary artery disease, low testosterone, prostate cancer treatment, Peytons disease, and the various options for management. So erectile dysfunction is simply the inability to achieve or maintain an erection that's adequate for sexual intercourse. It's extremely common. About 20% of men over the age of 20 experience erectile dysfunction in a lifetime, and more than half of men over age 40 have some degree of erectile dysfunction. It's affecting approximately 40 million men currently. So what's the physiology? So this is a cross-section of the penis, and on the left you see the flaccid state, and if you can see if we can get the cursor. Yeah, so underneath here is the urethra. That's where urine passes, and that really is not involved at all in erections. What's involved with erections are these two cylinders here called the corpora cavernosa, and they run the length of the penis from inside the body all the way to the tip of the penis. And when a man becomes aroused, these spaces in the corpora cavernosa dilate, and the arteries increase in size, so you get increased blood flowing in, and the veins taking blood away from the penis are compressed, so there's less blood flowing out. You have more blood flowing in, less blood flowing out. That causes increased pressure, and the penis thus gets hard. So erectile dysfunction is associated with a variety of medical problems, primarily diabetes, vascular disorders such as high blood pressure. Many medications can lead to diabetes. It's also related to treatments for prostate cancer, and it's of course related to heart disease. So first, let's talk about diabetes. Diabetes is extremely common throughout the country. Over 15 million men have diabetes, and about 50% of men with diabetes are going to have erectile dysfunction at some time in their life. Also, patients with diabetes typically have a more severe form of erectile dysfunction than others. It's more difficult to treat. Factors in those with diabetes that can make erectile dysfunction worse is advanced age, how long they've had the diabetes, how well controlled or poorly controlled the diabetes is, whether they have complications from their diabetes causing vascular problems, blood flow to their feet, etc., and if they have associated heart disease. And how about the relationship with heart disease while we're on that subject? So erectile dysfunction is a vascular disorder. It's a problem with those blood vessels in the penis not dilating properly. And heart attacks come from blood vessels in the heart not delivering blood to the heart muscle. And these two things are related. They're both vascular disorders. And actually, it's interesting, in 70% of men who have heart attacks, if you go back, they have had some element of erectile dysfunction previously. So it's a bit of a harbinger for heart disease. So patients who have erectile dysfunction, they have poor blood flow. It's often helpful to pay attention to their heart and make sure that they're doing everything they can to minimize the risk for heart attacks in the future. So we all know what to do to help avoid heart disease. Good diet, low-fat diet, regular exercise, don't be overweight, quit smoking, and reduce stress. And let me emphasize about smoking. Smoking, the nicotine causes constriction of blood vessels. So that's going to exacerbate any erectile dysfunction. It constricts the blood vessels, and erection requires dilation or opening of the blood vessels. So smoking is a double whammy. It not only causes the blood vessels to narrow further, but it also causes long-term damage to those blood vessels, not only in the heart, but also in the penis. Now about erectile dysfunction and low testosterone. Low testosterone is extremely common in this country. Approximately 40% of men over the age of 45 have low testosterone, and it's more common in men who are overweight, who have diabetes, who have high cholesterol and high blood pressure. It can cause a variety of symptoms, including fatigue or loss of energy, decreased strength or exercise tolerance, increased body fat, and difficulty in losing. If you're trying to lose weight, it makes it more difficult. It also can cause hot flashes like women get when they go through menopause. It also has psychological effects. People with low testosterone have more anxiety or irritability or depression. And of course, it also reduces your sex drive. It decreases your libido and makes it more difficult to have erections. Let me just go back. So if you have low testosterone, it is something that is easily managed by your primary care physician or your urologist. We can replace testosterone with a variety of treatments, including injections, gels, they're now pills. There are a variety of approaches to replace your testosterone. Now, there are potential side effects, which I don't want to get too much into the details of all that, but suffice it to say that this can be treated, and with appropriate monitoring is very, very safe. And what about prostate cancer? How is erectile dysfunction related to prostate cancer? So the nerves that are important for erections lie slap up against the prostate. And here in this upper image, you see the bladder, the prostate, and the urethral sphincter is here. The urethra goes through the middle of the prostate. These yellow things are the nerves that lie slap up against the prostate. So when you have prostate cancer surgery and the entire prostate is removed, these nerves are easily damaged. Also, if you have radiation therapy for prostate cancer, similarly, the nerves are at risk for being damaged by that radiation therapy. So if you have erectile dysfunction after prostate cancer treatment, it is treatable with all the treatment options that I'll be getting to later, but it tends to be more resistant to treatment than if it's just from, say, high blood pressure, diabetes, or heart disease. It tends to be more profound and more, it does not respond as easily to therapy. And then Peytons disease. Peytons disease is something that many people don't know about, but actually is fairly common. About 8% of men have Peytons disease. And all it is scar tissue that forms in the penis and causes penile curvature. So it actually can have several effects. Not only does it cause penile curvature, which can make it difficult to have intercourse just simply because of the angle of the penis, but it also can influence or negatively impact the blood flow in those corporal bodies, in the corpora cavernosa, and lead to erectile dysfunction. But fortunately, Peytons disease also is treatable. There is an FDA-approved medication now called Xiaflex. It's an injection that is given into that scar tissue that forms in the penis. There are also surgeries available and other options to manage this problem and lead to correction of the erectile dysfunction that may be associated. So what can we do to treat erectile dysfunction? Erectile dysfunction is very common, as I said, and most primary care physicians are perfectly comfortable managing this problem, particularly with the simpler forms of therapy. If those fail, then typically patients are sent to their urologist, or particularly a urologist that specializes in men's health and prosthetic treatments. So these are the basic treatment options. We have oral medications, we have injections, we have a vacuum device, urethral suppositories, and penile implants. So the pills are, you've heard of the little blue pill or Viagra. Cialis is the medication that they used to have those ads with the husband and wife in their bathtubs. I don't know where that came from. These medications actually are often very effective, particularly in patients who have early onset erectile dysfunction. And there are pros and cons to each medication that's used. So you have to find the one that works best for your lifestyle. There are different costs involved, different side effect profiles. Actually, it's kind of a funny story about how they came up with Viagra. That was the first pill that they found that worked for erectile dysfunction. But actually, Viagra was originally designed as a medication to treat high blood pressure. And the drug company that was studying this had a trial where they gave this medication out to a group of men to see if it would improve their blood pressure. And after a few months, they realized that it really wasn't working. And so they decided to cancel the study and figured it was a lost cause. And they asked for the men to bring all the medication back, and they weren't bringing it back. And when they asked questions, they realized, oh, their erections are much better. They don't want to give this medication back. And they're like, aha, maybe we can use it for treating erections. And sure enough, it's been a game changer. So Viagra is given typically about an hour before you want to have sex. It lasts in the body for 4 to 6 hours, but it is affected by whether you eat or not. I mean, most people like to have a nice meal and a glass of wine, and then they take their pill. Generally, it's not going to work very well because it's not going to be absorbed. So you really need to take it 30 minutes before you eat or an hour and a half after you eat. It used to be very expensive, and it still is. The brand name Viagra can be up to $30 or $40 per pill. But now we have generic Viagra available. It's called sildenafil, and that you can often get for $1 or $1.50 a pill. So that is much better. Cialis is also a good drug. Has a longer half-life, so it lasts up to 36 hours. So you could take it Friday evening, and it's working Friday night, Saturday morning, Saturday night. So you have a much longer window of opportunity to use it. You can also use low-dose Cialis and just take it daily, so you don't have to time the use of the medication. The side effects are all pretty similar. They can cause headache or nausea, stuffy nose. The one big thing that you must remember is that if you have heart disease and carry nitroglycerin, you cannot take these medications with nitroglycerin. It can cause a profound drop in your blood pressure and can potentially be fatal. So if you don't have heart disease, you don't take nitroglycerin, no worry whatsoever. They're very, very safe medications. But if you carry nitroglycerin, there are many patients who carry it but have never taken it. So if you're one of those people, you carry it, you've never taken it, and you're taking Viagra or Cialis. Well, if you take Viagra or Cialis and then get chest pain, don't take a nitroglycerin. What you should do is take an aspirin and go to the emergency room. It's a big no-no to take nitroglycerin when you've got one of those medications in your system. So the next step, if pills don't work, many patients will try a vacuum device. This also is a very effective treatment. It's a plastic cylinder that goes over the penis, and you have either a manual pump or a battery-powered pump that draws air out of the cylinder, which draws blood into the penis and makes the penis hard. And then you can use a constriction band, which is like a specialized rubber band at the base of the penis to maintain the erection. So many patients use this, and sometimes they'll use it with a pill, with Viagra or Cialis, to get an adequate erection. But there can be problems with this treatment as well. Because of that rubber band being quite tight, it can block your ejaculation, which can be uncomfortable. You can get bruising of the penis, and sometimes patients complain of coldness of the penis because it keeps blood flow once they have the erection. And some people find it to be uncomfortable or mechanical and not very satisfactory. But some people really like it. So it's again, you have to find what works for you. Urethral suppositories are another form of therapy. Basically, this is a medication that's in a little pellet that's placed in the urethra, and it dissolves and is absorbed into the corpora cavernosa, those erectile bodies that I mentioned earlier. And that leads to relaxation of the blood vessels in the penis, just like the pills, Viagra and Cialis, help to relax those blood vessels. So this treatment does work, but there can be side effects again. All treatments can have potential side effects. So discomfort is probably the number one side effect. And some people will get a little lightheaded when they use this medication. And I would say that although it's a good option for some people, many people find it to be uncomfortable to insert and just not a very satisfactory option. Now, injection therapy is another option that this is very effective and it's very popular. Actually, well, the way it works is you inject medication into the corpora cavernosa, right into the penis, every time you want to have an erection, which sounds awful, but it's a very small needle, and most patients are able to do it successfully. And it usually is very effective. And basically, this medication works just like the Viagra and Cialis works in terms of relaxing those tissues, except it's much higher concentration, so it's more effective than the pills. And when you hear these ads for a place like New Mail Medical or Rocky Mountain Men's Clinic, and they make a claim such as, we'll give you a treatment, and if you don't have an erection by the time you leave, we'll give you your money back. This is what they're talking about. They're talking about these injections. So this is something that, again, all urologists are comfortable prescribing this treatment. It is a very good option for many patients and does lead to very good erections for the most part. But there are, again, potential side effects. You have to give yourself a shot every time you want an erection. For some people, they're just not going there. You can get discomfort with the medication. It can potentially lead to scarring where the needle is going in, particularly if you're using it over many years. The main risk is that you can get an erection that lasts over 4 hours. Now, I'm sure you've heard these ads for Viagra and Cialis where it says, if you have an erection over 4 hours, contact your doctor. I have never, ever heard of a patient getting prolonged erection with Viagra or Cialis. However, with these injections, it's actually something we do see fairly regularly. And that's because when you use these medications, the injection, you have to be careful how much you use. So we start patients on a very low dose, and we gradually increase the dose to get the patient to the point where they get an adequate erection for an adequate period of time. And as long as they stay there, they're going to be safe. It's when they increase the medication beyond that they can get into trouble and have an erection that lasts more than 4 hours, and that requires emergency intervention. So typically after 4 hours, if there's an erection, the patient has to come into the office or come into the emergency room to be managed and have that problem resolved. So now let's move on to a penile implant or a penile prosthesis. Basically, the way this works is you have two cylinders that are placed in the corpora cavernosa. The cylinders that I mentioned that are the erectile bodies in the penis. There's a reservoir up inside the abdominal cavity which holds saline or salt water solution. And there's a pump in the scrotum that allows you to inflate and deflate the device. 98% of patients find this to be a very satisfactory or even excellent treatment option. And for the most part, this is a permanent solution. 94% of patients after 7 years are still using it regularly. But there can be side effects, as with any treatment. Certainly the initial surgery is, to put this in is, I don't want to sugarcoat it. It is a surgery and does require an incision, although it's a relatively small incision, only about 1.5 to 2 inches long at the base of the penis, and we can put all three components in through that one incision. There is some bruising and swelling, and it takes a week to 3 weeks afterwards to completely heal up and feel back to yourself. Now you can walk and drive the following day and do normal activities, so it's really generally quite well tolerated. I'm going to show you a video that demonstrates the device in a kind of a cartoon form. It takes a little while to load. But this shows the male anatomy and with the penile prosthesis in place, and you can see what the patient is pumping, the pump, fluid is running from the reservoir through the pump and into the cylinders, and it makes them hard. And then when the patient is finished, he pushes the release valve, and the fluid runs from the cylinders back through the pump and back into the reservoir, and the penis becomes flaccid again. So that's a nice solution for many patients. It's completely inside of your body. So if you were naked in a locker room, no one else would know that you had this. It's very reliable and allows for a lot of spontaneity. So when you, if you want to have sex, you reach down, you pump on that pump a few times, and you have an erection. So literally within a few seconds, you're ready to go. And when you're done, you release it, and you're done. And so it is a very convenient solution for many patients. It does not interfere with ejaculation or orgasm. And this has been around for a long time, for 40 years. 500,000 patients have been treated with a penile implant. So they have a lot of history. There is potential risk of infection with these. And we are very, very careful with our patients to prepare them for the surgery to minimize that potential risk. And with our protocol, our risk of infection is less than 1%. And there's potential for device malfunction down the road. But with their years of manufacturing this and extremely good quality control, fortunately, that risk is minimized, but not completely eliminated. But it's quite good. And if something happens down the road, we revise the device. We remove the broken part and put in new as needed. A lot of people are worried about the cost of the penile prosthesis. Although insurance coverage cannot be guaranteed, for the most part, Medicare and private insurance companies do cover the penile prosthesis. You may have a deductible or copay, but for the most part, it is a well-covered procedure that we do not have any problem having this covered by the patient's insurance carriers. If for some reason you're in a situation where you might be self-pay or your insurance isn't going to pay for it, which actually I can't recall ever having a situation like this, the company does have an assistance program to help out with the situation. So there are potential risks, which I mentioned: mechanical failure, infection, discomfort initially. I really haven't had any problems, although rarely patients down the road can have pain or problems with their prosthesis. It's very low risk, less than 1% chance. So to summarize, erectile dysfunction is a very common problem and is associated with other health conditions such as diabetes, heart disease, high blood pressure, low testosterone, and of course treatments for prostate cancer. And good lifestyle is not only going to help manage those problems, but it will also help ameliorate your erectile dysfunction or help decrease the risk of developing erectile dysfunction. There are a variety of treatment options, and it's kind of a nice situation because we have so many treatment options that it really allows patients to customize their treatment that works best for their lifestyle, their situation, and with their partner. I mean, this is a partner, it's a partner decision. I mean, we need to have a solution that works both for the patient and their partner to allow them to be intimate and allow them both to be comfortable with the situation. And so mixing and matching these various treatments can be done to achieve that goal. So talk to your partner and talk to your urologist or your primary care physician. And if you want to be intimate, there's no reason not to be. You know, a lot of men think, well, erectile dysfunction is just a natural consequence of aging, and they feel that they shouldn't do anything about it. But what I tell people is, hey, this is just another bodily function. You know, if your eyesight gets weak, you get eyeglasses. If your hearing gets weak, you get a hearing aid. This is just another bodily function that can be treated if you want. And there's no reason to go without intimacy if you don't want to. Okay, so I think there's some questions now. So, Ann, if you could come over.
Yes.
Stop sharing the screen so you can see me and I can answer the questions. Can you hear us? So I have gotten some questions, and I'll just I'll answer them. Should I hit answer live, or do I just read them? Okay. Okay. All right. So I presume you all can now see me and hear me. So the first question is, do the medications increase or dilate the vasculature in other places as well? I tried these post-surgery and radiation treatment and only effect was severe headache. And the answer is absolutely. That's why headache is the most common side effect with both Viagra and Cialis. That's because of you're getting dilated blood vessels in your head. Also, some people get a little dizzy, they get flushing in their face. So those are all related to that dilation effect. Unfortunately, if you're just getting a headache and you're not getting erectile dysfunction, or excuse me, you're not getting an erection, it means that the blood vessels in the penis just aren't responding adequately to those medications, and obviously you're going to have to move on to some other form of therapy. Particularly after prostate cancer surgery, radiation therapy, it's pretty common that you end up needing injections to get adequate dilation in the penis. One advantage of the injections is those don't cause dilation elsewhere, so you're not going to get a headache with those treatments. The next question is, are there any over-the-counter meds to help with priapism or that's an erection that doesn't go away, or an erection that lasts over 4 hours? And the answer to that is yes, there are. So it's, again, because the medications are causing dilation of the penis, we want to constrict the blood vessels to correct the priapism, or that prolonged erection. And the most common one would be Sudafed. Sudafed is used for sinus congestion. And you can just go buy some Sudafed and take 2 pills. Usually I would recommend, if you're using the injections and you have a full erection after you've had intercourse and it's not going down, go ahead and pop a couple of Sudafed right then, and maybe repeat it after 3 hours if need be. All right, next question. Can a patient use erection medications in conjunction with the injection? And the answer is yes. As I said, you can mix and match. You can use Viagra in conjunction with injections. The one concern, though, is that you don't want to be doing this willy-nilly because, again, you don't want to get that prolonged erection. So if you get too much of an effect, then you're going to get that prolonged erection. So you need to be careful if you're going to be using Viagra or Cialis in conjunction with the injections, you want to start with a low dose of the injection with the pill, and you only just change one thing at a time. You know, either increase the pill or increase the injection, but not both at the same time. Okay, next question. How much erectile dysfunction can be attributed to use it or lose it, specifically multi-year lapse in use? So the answer to that is not a thing, in that, you know, if you're not sexually active for several years, it doesn't mean that you lose the ability to have an erection. But the problem is you're now that many years older. And so whatever else is going on in your body in terms of, you know, say, high blood pressure, diabetes, if you're overweight, if your testosterone level has gone down, all these other factors may have gotten worse, and so your erectile function may be worse as a consequence of that. Okay. About the penile implant procedure, what if I have a sensitivity to pain in the scrotum? Well, we all have sensitivity to pain in the scrotum, I'm afraid. And there is, you know, I don't want to, again, sugarcoat it, but it is, you know, so there's discomfort initially. We give pain medications to help control that. And most patients tolerate it just fine. Now, if you can't stand touching your scrotum right now, that may not be a good option for you, because you're going to have to manipulate this pump that's going to be inside the scrotum. And so you got to be able to do that. Of course, you're not squeezing on the testicle, you're just squeezing on the pump inside the scrotum. But if you feel like your scrotal skin is too sensitive, then that's something that, you know, you're going to have to decide. That's, you know, you could come in for a consultation, and I could show you the device, and maybe we could experiment a little bit. I can explain about how much pressure is required, and you can see whether that would be a thing for you. Speaking of pain medication, by the way, while I'm on the subject, you know, there's this opioid epidemic in the country, and most people don't realize that narcotics cause a profound drop in your testosterone level. The narcotics suppress your pituitary gland in the brain, which stops sending signals to your testicles to make testosterone. And so when patients are taking narcotics over a long period of time, their testosterone levels usually are profoundly low. And then that can, of course, lead to erectile dysfunction. Okay, next question. It has been a year since my prostate was removed. There were some nerves spared. I'm 64. Do you think I still have a chance on getting the ability to have an erection with just pills back someday? Well, if it's been a year and you haven't had any luck so far, I'm thinking it's probably not going to happen. You never say never, you never say always, but I think you probably you're going to need some more, you know, different treatment than just the pills. Now, that being said, if you were, let's say you go on injections and now they work well, you could, you know, periodically try the pills. You know, you don't lose, just using the injections doesn't mean that you can't go backwards. You can't go back and use the pills down the road. It may be that, you know, 6 months or a year from now, maybe you will respond to the pills. So that would be okay to do as well. Okay, next question. How long after prostate surgery should it take for the nerves to function properly? Well, usually we'll give it 6 months to a year. So if it hasn't happened by a year, most likely it's not going to happen. I would say that for the most part, if you're at 6 months and you're not getting any erections, I'm not saying it can't happen, but you need to start thinking that this may be a long-term problem for you. You know, I don't want to be overly optimistic and make you think it's going to happen when it might not. And you know, the thing is, you know, if you want to be intimate, you don't have to wait. Again, using the injections doesn't mean that things aren't going to come back. So, or using some other treatment, things aren't going to come back. So it's perfectly reasonable to go ahead and start treatment now. And hopefully if things get better, you won't need any treatment 6 months from now. And in the meantime, you can enjoy your intimacy. Okay, next question. People talk about oxide LDL inflammation. Is there a correlation with erectile dysfunction in this inflammation? I'm not familiar with oxide LDL. LDL is, I presume that's low density lipoprotein, which is a type of cholesterol. It's the bad cholesterol. So assuming that's the case, then yes, certainly if you have a high amount of this bad cholesterol, the low density lipoprotein, that's going to put you at increase for hardening of the arteries, stiffening of the blood vessels, and that is directly related to what causes erectile dysfunction. So yes, I would think that that is related. Okay, this next question, what is the new treatment Dr. Montoya is now doing? All right, this question is related to ultrasound technology called CoreWave, where we actually stimulate the blood vessels in the penis to improve the elasticity of those blood vessels and improve the chance for erection. The reason I didn't mention it in the webinar is because it's not FDA approved, so it's not covered by insurance. But it is pretty exciting technology. It typically is given as 6 weekly treatments, about 30 minutes per week for 6 weeks. Doesn't hurt, and it stimulates the blood vessels with ultrasound technology. And the initial data shows about 70% of patients do see improvement in their erections with this treatment. So it's pretty cool because it's actually kind of curative in that you're turning back the clock on those blood vessels, making them more elastic and more pliable. But because it's not FDA approved yet, I didn't want to overly tout it, but it is certainly an option. And but I will say it's not a home run. So it's not going to, let's say if you've had prostate cancer surgery and you have no erections and you need injections, this isn't going to make it so you're normal again. It might, if you're on pills and the pills aren't working so well, and you're thinking about going on injections, it might allow you to stay on the pills for a longer period of time. Or if you're thinking about going on the pills because you're having intermittent episodes of erectile dysfunction now, but you're not doing any other treatment, it might make things better to the point where you don't need to go on the pill. So it's kind of a one-step improvement that we've seen. It is nice because it doesn't hurt, and there's no bruising associated with it. There's another form of this, what we call low intensity shockwave treatment called Gaines wave therapy. What we do is core wave therapy, and that has pretty good data. The Gaines wave therapy is done by a lot of these other places that you hear advertised on the radio, if they're talking about that. And the Gaines wave their data is much, much worse, and it's also a lot less, it causes them a lot more discomfort. So not as good of an option in my mind. Okay, next, can putting off dealing with erectile dysfunction make it more difficult to treat? Well, again, as you get older, the underlying problems that are leading to erectile dysfunction aren't getting better generally. So ongoing high blood pressure, diabetes, being overweight, whatever it might be, that tends to just lead to ongoing problems. So I think that if you want to be intimate and you're having trouble now, why wait? It's like if your eyes are getting weak and your glasses aren't as good, you have to upgrade your glasses. It's just something that you have to do. And so I would recommend you just go ahead and take care of it so you can enjoy intimacy now, and there's no point in waiting. Okay, next question. Can you discuss the additive effectiveness of multiple treatments for prostate cancer, surgery, radiation, and hormone therapy, specifically Lupron on erectile dysfunction, And how long does one wait until implant? Well, that's a lot of stuff to make it a problem to have erections. And you know, the Lupron will drops your testosterone to basically zero. So that's a problem, and most patients aren't, you know, their sex drive and their ability to have erections basically goes away with that treatment. Hopefully, though, you're not going to be on Lupron forever, maybe for 2 to 3 years, or maybe even, you know, maybe shorter, maybe 6 months. And once you come off of that, then your testosterone will recover. But then you also have the additive effects of the radiation and the surgery on your nerves. And if you have surgery and radiation together, that's a pretty bad prognosis for your erectile function. So if I would say you're probably going to need injections, I would give that a go. But if the injections aren't working, then I think you're probably just going to need to go to the penile prosthesis. I don't think there's going to be, you know, you may want to give it a year, maybe 2, before pulling that trigger. But I think that's probably what you're going to need. Okay, next question. Can you expand on the use of testosterone and how it relates to plaque, inflammation, bone health, and do the testicles stop producing any testosterone if testosterone injections are used? So testosterone is, you know, it's a very valuable hormone, as I mentioned, in terms of your energy, your exercise tolerance, your sex drive, and your ability to have erections, your mood, and your bone health. And if you don't have enough testosterone, you can get osteoporosis. So it is a very valuable hormone, and really can make patients feel so much better when they're on testosterone. Now, as far as plaque is concerned, I don't think testosterone is really, there's any relation to plaque. Now, there was one study that suggested an increased risk of heart disease if you were on testosterone. What we actually have found, the opposite is more true, that if you have a low testosterone, you have more risk of heart disease. And that kind of makes sense, because if you have a low testosterone and you don't have the energy to get up off the couch and you gain 30 pounds and you can't exercise, you know, that seems like a setup for heart disease. So I think having adequate testosterone is good for bone health. It's good for your heart. It's good for your overall health. Now, the testicles do stop producing testosterone if you're taking testosterone. That's one of the side effects. Because if you take testosterone, your pituitary gland in your brain thinks, oh, well, we have enough testosterone, we don't need to make any more. So it stops sending the signals to your testicles, and they actually will shrink up. They'll atrophy because they're not making testosterone. Also, they stop making sperm. I presume this audience isn't particularly interested in fertility, but in younger men, if they're taking testosterone, a lot of them don't realize it's making them infertile. So yeah, testosterone, your normal production does go down if you're getting testosterone. Now, that can be ameliorated. There are medications that we can give you to help support the testicles, keep them making testosterone if that's important to you. There are pills and shots that can be used for that. Okay, next question. If one levitra is somewhat successful, is 2 more successful? So probably yes. I can't, as levitra, I think the maximum dose is 20 milligrams, so I'm not sure what dose yours is. But generally, you don't want to go over what is advertised as the maximum dose. So yeah, more generally does work better, but you're going to get more side effects. And I'm always shy about letting patients use more than the recommended maximum dose, simply because of you know, if you get really bad side effect, that would be a bad thing. Okay, so the next question is, please discuss wave therapy for erectile dysfunction. That's what I was talking about earlier, that core wave therapy that I mentioned, the ultrasound technology, or what the other providers in the area use, this Gaines wave therapy. The Gaines wave is not ultrasound. The Gaines wave is actually a physical impact on the tissue, so you can imagine that is much more painful than ultrasound is. And the ultrasound, the data on ultrasound so far is pretty good. As I said, about 70% of patients say they see significant improvement. But like I said, it's not going to take you, if you've had prostate cancer surgery and radiation and you're not getting erections with injections, this the core wave isn't going to cut it for you. But if you have mild erectile dysfunction, I think it is a reasonable option, but you have to be willing to pay out of pocket because it's not FDA approved. It's not going to be covered by any insurance. So it's about $3,000 for a course of therapy out of your pocket. It doesn't.
Sorry to interrupt.
Okay.
Thank you.
I have not seen them, but I'll get through these and then we'll go to the chat. Okay. Does an implant need refilling the chamber after a few years? Only if it develops a leak. So that's one of the reasons why we have to revise these. If it springs a leak for some reason, then you have to refill it. Well, you don't refill it. What you have to do is replace it because it's got a hole somewhere, and typically you don't know where that hole is. Typically, though, if there's a hole, it occurred when the implant was implanted, and you're going to know it within a few weeks to a few months of it being implanted because there was some technical problem. Fortunately, we take extreme care to avoid that from happening, but it is a possibility. Okay, what do you consider a normal range of testosterone for males over 50? I'm at 342. Wonder if this is on the lower side of normal or okay. Or are there OTC supplements that are effective in boosting testosterone? So what's normal? The normal range for testosterone is quite broad. It goes from about 175 up to 780. It's a really wide range. And some people have a testosterone of 200 and they feel fine, and other people have a testosterone of 500 and they don't feel fine. They feel terrible. So there's a lot of variability. And the thing is, just your total testosterone number is not the whole story. One thing we can measure is what your free testosterone is, or your bioavailable testosterone. That's a calculated number where we use other proteins that can bind testosterone in your bloodstream and keep it from doing what it needs to do. The two proteins we look at primarily are albumin and one called sex hormone binding globulin. These proteins bind testosterone and prevent it from doing what it needs to do. So your testosterone 342, if we calculate your bioavailable testosterone, it might be that it's low and that you would benefit from getting testosterone. Sorry. The other thing that we don't know is what's going on with the testosterone receptor. You know, the testosterone receptor on your cells, some people may have a very sensitive receptor and they don't need much testosterone. Other people may have an insensitive receptor and they need a lot more testosterone. So it's very variable. And that's not something we have any science on related to this receptor. So I can't measure that. So it's really all about how you feel. And if you have all the symptoms of low testosterone, we find you have a low bioavailable testosterone, even if your total testosterone is normal, I'll consider treating you. Okay, oh, and the over-the-counter supplements. No, I'm not a fan of the over-the-counter supplements. There are a lot. There's a lot of them that claim to boost your testosterone, and I'm very worried about what they put in those things. And there are a lot of side effects with taking testosterone. You need to be properly monitored. So I would, personally, I think you should steer away from those over-the-counter supplements. And if you're going to, if you want to manage your testosterone, go to your primary care physician or talk to your urologist. Okay. Is the ultrasound treatment contraindicated if a patient has had prostate cancer? No, it's not contraindicated, but again, if you have profound erectile dysfunction and you need injections, I don't think the ultrasound treatment is going to do it for you. If you're managing with pills and would like to get off the pills or maybe lower your dose of the pills, then it probably would be helpful. Is it normal for the penis to have less sensitivity as men grow older? Yeah, I think that's related to testosterone and blood flow issues. So that is a relatively common thing that people mention, but unfortunately, I don't have a great solution for that. I guess it does make sense to have your testosterone level checked, and if that is low, perhaps it'll get better with replacement, but I can't guarantee that. And what effect would bladder cancer successfully treated with BCG have on erectile dysfunction? Really should have zero effect on erectile function. Bladder cancer, the bladder has nothing to do with erections. BCG therapy has nothing to do, would have no side effects related to erectile dysfunction. So if you're having erectile dysfunction, it's for some other reason. Okay, now I'm going to go to the chat, and these are handwritten questions. So one of the questions is, should I see my primary care doc before seeing my urologist? That's up to you. Many primary care physicians feel comfortable evaluating patients for low testosterone and erectile dysfunction, and are perfectly comfortable treating you, particularly if you're going to respond with pills, are perfectly up with that. If you need more aggressive therapy with injections or a vacuum device, or certainly penile prosthesis, then you need to see a urologist. Is it possible to get a copy of the slides? I don't see why not. We're going to actually try to post. We'll post this on the website, and I'll let my IT specialist get with you if you want to get a copy of the slides. Looks like Carrie said we were going to be sending out the links. Okay, thank you, Carrie. How effective are the pills in maintaining an erection? My issue is maintaining. I can have an erection with medication, but will often reduce or go away before an orgasm is reached. That is related to what's called a venous leak. As I mentioned, when the corpora cavernosa dilate, become enlarged, the veins become compressed, and less blood is flowing out. And many patients have this venous leak problem where the veins aren't being compressed enough, and so the blood is flowing out too rapidly. So you get an erection, but you can't maintain it. And that is exacerbated by stress and cold weather and underlying problems with your blood vessels. And basically, this is exactly what the pills are meant to treat. They're trying to treat the venous leak problem, but your problem is just a bit too severe to respond to either the medication or the dosage that you're using now. So you either are going to have to increase your dosage or go on to another therapy. With the injection, will the penis become erect to the previously normal size and shape? Okay, this is something we did not talk about. It's very common after prostate cancer surgery or radiation that patients experience a drop in their penile length and girth. And I'm not really sure why that is, but it's a very common complaint. And so the answer is probably not. The injections will allow you to have an erection. Perhaps over time you'll get some improvement. With the vacuum device, you can get some improvement. And with the penile prosthesis, that also, particularly in combination with the vacuum device, you can get some improvement. But generally it's not dramatic. You're talking about a half an inch to maybe an inch and a half total. Okay, I've been using 5 of the pills, 20 milligrams sildenafil. Can you use more if erection is not sustaining during intercourse? Well, 100 milligrams is considered the maximum dose for sildenafil, so I cannot recommend that you try more. I will say some of my patients do use more, but I certainly can't recommend that as a physician. So I guess that would have to be at your own risk, but probably you're going to need to try something else. We mentioned the core wave ultrasound technology. It may be that with that, then you're going to be okay with just 5 pills. Maybe you could drop it to 4 or even fewer pills if you did that treatment. But otherwise, you're probably going to be needing to combine it with a vacuum device or going to injections or something else. Are injections covered by insurance? That generally not. Injections are going to cost probably $10 to $20 per injection. So it's, I presume some insurance companies will cover it, but generally these medications have to be put together by a compounding pharmacy and is not going to be covered by insurance. You discussed more about the relationship of low testosterone and osteoporosis. I do not have erectile dysfunction, but recently had a parathyroid surgery. Sure. I mean, it's like women who go through menopause, they stop making estrogen there at increased risk for osteoporosis over time. This isn't something that happens right away, but it goes on, it happens over decades. And testosterone has similar function in men. So if you have a low testosterone and don't treat it, it's not something that's going to cause an immediate problem, but over decades could lead to problems with osteoporosis. So it's you should talk to I presume you have an endocrinologist. If you had your parathyroid removed, talk to your endocrinologist about maintaining your testosterone level, and that they're normally very happy to do that. But if you're worried about it, you can always talk to your urologist. Okay, well, I don't see any other questions. And we're at 1 hour, so I'm going to, unless somebody else wants to pipe up here, right now we're going to call it a day. I really appreciate everybody participating. If you have any questions going forward, we're available here at the Urology Center of Colorado. We have excellent staff and physicians, and we're always happy to help. So I hope you guys enjoy the evening, and call us anytime. Thank you.